Hello everyone and welcome to another STF, and this time Hepatitis Scotland webinar. Prevention saves a ton of cures, and we're talking about using prevention and harm reduction to ensure we can hit Scotland's Hepatitis C elimination target and maintain that. I'm Leon Wiley, I'm Lead Officer at Hepatitis Scotland. I'm also co-chair of the Scottish Sexual Health and Bloodborne Virus National Prevention Leads. The post-COVID economic landscape will likely be very uneven, and past experience of drug services suggests prevention efforts are often the ones that are squeezed first when money is tight. With World Hepatitis Day occurring next week on the 28th of July, Tuesday, this webinar aims to highlight broader thinking about how prevention and harm reduction can contribute to the Scottish Government's 2024 elimination target, and importantly, to also ensuring there are no future outbreaks once that goal is actually reached. The presenters today bring a wide range of experience, expertise and research that will explore current issues, but also alternatives to traditional ways of service delivery and thinking. We'll look at current research, service initiatives, what's happening in Scotland and wider across the UK. The treatment as prevention approach has had excellent results thus far in Tayside and Glasgow, but as we know, the transmission of HIV through injecting drug use is currently responsible for a third of new HIV infections in Scotland, and it's at the highest level since the 1980s. This has highlighted the need that we need to retain or maintain our personal and corporate memory and practice regarding all facets of harm reduction approaches, as workers and service users are often focused on what they thought are newer and more pressing issues. In Glasgow, there was quite good levels of harm reduction, but due to a combination of circumstance, the greater purity of and access to cocaine, and taking the eye a bit off the testing ball, we're still dealing with an expensive outbreak in people in monetary terms. The title today should perhaps say pounds of cure, because as we know, each viral infection we prevent saves very expensive treatment. The speakers today, we have three speakers who'll give a 10-minute presentation, followed by a Q&A session at the end. Attendees online now can submit questions throughout the webinar. The questions tab appears on the control panel, which should be down on your right side of your screen. My co-chair, Leslie Bond, who's the National Training and Development Officer in SDF Harm Reduction and SHBBV, will then join us for the discussion session at the end, where she'll summarise those questions being asked of the speakers. Our speakers today are Dr. Jenny Scott, who's a Senior Lecturer in Pharmacy Practice, University of Bath, and also pharmacist prescriber at Turning Point UK. Then we have Dr. Magdalena Harris, who's Associate Professor at the London School of Hygiene and Tropical Medicine. And then also Dave Little, who's the CEO of Scottish Drugs Forum. So first up is Jenny Scott, and over to you. Jenny, thank you.
Thank you, Leon. Good afternoon, everybody. It's really good to be here, so thanks for the invite. Right, I'm going to talk about recent experiences in the pandemic and what maybe we can learn to eliminate bloodborne viruses, and obviously hepatitis C being a focus, but as Leon's just said, HIV being very much back into focus as well. Okay, so I'm coming from the starting point of what we know. We know that needle and syringe provision and opiate substitution therapy reduce transmission of bloodborne viruses. So that's the starting point. And there were some very important messages in a Cochrane review from 3 years ago on OST and needle and syringe provision, which basically said, okay, they work and they prevent bloodborne viruses, but there's real variation in how they're delivered, and really called for more research and practice to scale up delivery and do so in an effective way. And what I think we've started to learn from the pandemic is ways we can do that. So that's what I'm going to talk about. So what happened in England? I'm based in the southwest of England, so despite the accent, I've been here a long time. So I'm going to tell you about what's gone on for us. So we were given instructions from Public Health England to really reduce footfall of clients and services and pharmacies, and alongside that, make sure treatment was optimised, make sure everybody had naloxone. And that's what we did. So we did that. We had seen quite creative ways of needle and syringe provision being delivered. We've seen more outreach, we've seen click and collect, we've seen postal services, we've seen ways to try and take services to people, particularly people who struggle to engage. Around prescribing, and that's obviously my area of work at Turning Point, we risk assessed everybody, but we made quite what you might call drastic changes to things like pickup regimes. The majority of people have gone on to either 2 weeks supplies of take-home OST or 1 week. And we've really just kept supervised consumption where absolutely essential. And we've supported people to shield with other people collecting their medication for them. We've, alongside that, done the actions around naloxone and provision of safe storage boxes. And our key workers are having a lot of telephone contact with people, with their clients. There's more telephone engagement. And in fact, the only people being seen face-to-face are really by people like myself who see people new into treatment, for people new starters. And even then, if it's somebody that we know absolutely wants buprenorphine, perhaps they've had it before, particularly if they're known to the service, we're doing that on the phone without urine drug screening. So we use quite a lot of buprenorphine already, and obviously differences in risk, that's the approach we've taken. So what happened? What happened as a result? Well, it's important to say that the research is just really starting on this. So I'm going to tell you some feedback from our clients, and then about a couple of projects that have we know some of the data from, and then talk a bit about future changes. Our clients overall have really responded positively to what we've done. I think what we've seen highlighted is how different and how outcomes for people can be really variable. The majority of people have really enjoyed the increased contact with their key worker, the telephone contact, the intensity of some of the interventions that have been taken to them. They've liked the flexibility of take-home dosing. They feel less stigmatized, more in control of their medication. And people have obviously, that has been the backdrop of not normal circumstances. So things like reduced access to drugs, shops being closed, problems with accessing money, for example. And a few people have struggled. You know, we've had a couple of people who've found it difficult having lots of medication at home, people who've requested to go back to daily pickup, or people that we have felt we should put back on that regime. But overall, I think it's fair to say it's been very positive feedback from our clients, and we are actually starting some research on that in about a week. So a couple of research projects that have already reported. This one's from Liverpool, where they've looked at needle and syringe provision in Cheshire and Merseyside. They've shown that there's been a reduction in visits, a reduction in equipment supply, and coverage has halved really. And you know, coverage was never good anyway. At the start, before the lockdown, their data suggests about 50% coverage, going down to 25%. And we know from research in Scotland and in England, actually that figure needs to be about 150, 200% if we're talking about bloodborne virus prevention. So that's a concern that's got even more concerning. And talking to one of the study authors yesterday, he feels that the explanation for this is about accessibility, problems with transport, pharmacies having long queues, reduced opening hours, people being concerned about asking for a needle exchange in a pharmacy where that being asked to socially distance and other people might see them or hear them, and people being afraid of going out, particularly early on in the pandemic, of you know, being outside. I also want to mention a study going on in Bristol, which is called Lucid B, Living Under Coronavirus and Injecting Drugs in Bristol. This is led by Lindsay Hines at Bristol, and there's several of us working on this, including me, and in close partnership with Bristol Drugs Project. And many of the interim findings, which I've got here, echo the things that the authors in Liverpool have mentioned around needle and syringe provision. So these challenges of access, difficulties getting needle and syringe provision and opiate substitution therapy because of long queues and travel disruption, etc. And people presenting a mixed pattern on their drug use, many people using less, finding it easier to use less, feeling quite supported or that the environment is quite supportive of that. But a few people saying, actually, I've used more because I'm bored and I'm stressed and my mental health is suffering. So again, a mixed picture from people, just like we're hearing from our clients. But overall, particularly around the changes in supervised consumption and opiate substitution therapy pickups, mostly being welcomed by people, that autonomy and that ability to be more flexible and more normal and being treated like another pharmacy customer. So what about this lack of supervision? Surely we're absolutely terrified about drug-related deaths. I think the backdrop is, talking to clinicians I work with and others, I think they're always surprised to learn that the evidence base that supports supervised consumption isn't desperately strong. You know, we have some ecological data that shows that when supervised consumption was introduced, it coincided with the fall in methadone-related deaths, but of course, we also at that same time had an increase in OST provision and more knowledge on dose optimization. So it's quite hard to unpick. We've got other studies that don't really say there's any impact on mortality or other outcomes. And we've got work from Magdalena, who's going to talk to you next, and her colleague Tim Rhodes, that actually talks about the positive aspects of methadone diversion, which of course supervised consumption aims to prevent around many factors, but one of those being preventing people injecting, so reduce bloodborne virus transmission. So I think it's fair to say that the literature on supervised consumption says most people don't like it, although a few people find it helpful. Again, a mixed picture. And Leon talked about cost and cost of treating bloodborne virus infections. Supervised consumption obviously is a cost as well. So we've got this natural experiment opportunity at the moment with the pandemic, where we could study the impact of this big drop in supervised consumption we've had in England, you know, and see what impact that has had on both drug-related deaths and hospitalisation of people who use drugs. So just to finish, what should we keep doing? What should we do going forwards? Now, it's important to say that most of the data, the research hasn't been done yet for obvious reasons, that it's too soon. So these are my own reflections. We obviously need that data to really inform final decisions. But from what I've seen as a practitioner working in a drug service, is that the flexibility that we've got at the moment with clients needs to be kept. And to work under that flexibility, you need a confidence, you need a knowledge of what contributes to risk and how risk can be managed. So we need to be able to treat each of our patients individually according to their circumstances. We need to be able to think, I think, about supervised consumption as being a complex intervention. That's an academic term around public health interventions, but something that actually it's not simple. It doesn't do the same thing for everybody in the same circumstances from a variety of pharmacies. We need to look at how to unpick when we can use it to achieve intended consequences and what the unintended consequences might be. Because there are concerns, I have concerns that, you know, actually it might be doing things we don't want it to do. So we need to understand the interplay between, for example, suboptimal, optimal dosing and supervised consumption and the outcomes. We need to know when might we actually increase risks rather than decrease risks. What's the impact of taking away the autonomy someone has? And we need a cross-disciplinary debate about control and coercion. And what I would like us to think about is how we can scale up. So to meet this target for bloodborne virus prevention, scale up of OST, we've already talked about NSP is going to be vital. How can we scale up OST? And within that, how we use supervised consumption so that we really engage as many people as possible, so that we use supervised consumption selectively, and so that we really manage risk and help people feel that their drug treatment is working for them and that the outcomes are really the best they can be. And as I say, that we can prevent transmission. So that's me. Thank you very much. I am going to now mute myself and disappear, and you can, oh, and there's references you can look at later if you wish. Thank you.
Thank you, Jenny. That was great. And that's an example of the things we need to think about when we're looking at prevention. It's not just it's not just equipment, it's about the whole process of people's access to services and having their own agency about their use. So next up, we have Dr. Magdalena Harris. She's Associate Professor at the London School of Hygiene and Tropical Medicine. She's published very widely. There's been a veritable deluge of publications in the recent past, which has been great. There's some really interesting reading if you want to look up some of her stuff after this, but I'll hand over to her now. Thank you, Magdalena.
Cool, thanks Leon. It's great to be here. Really nice to hear Jenny talk as well, and it's good actually because Jenny preempted and covered my first slide, which means I can concentrate more on some other stuff that Leon asked me to talk about. So really, I want to talk about how we can learn from peers and pleasures and pragmatics. I'm going to go back to talking a little bit about some of my earlier work, but also, so this slide is really, it refers to exactly the same study that Jenny talked about, and I thought it was important to bring it up in case nobody else did in relation to the current COVID context. You know, what we are seeing is that NSP attendance and needle and syringe provision is decreasing, and obviously that's a real concern. It's completely no surprise in the current climate where you're having people fearful of going out. They're going to feel like they're more visible in pharmacies. You know, there's issues with stigma, all of these things. But it's been great to have this research evidencing that, that in the northwest of England at least, visits and clients have been down by 36%, and they, as Jenny said, that they estimated that coverage had halved. You know, and this is really concerning. The authors say the decline in NSP coverage is so marked that it almost certainly reflects decreased utilisation amongst those in need, indicating increased equipment reuse and risk. And obviously this has implications for hepatitis C transmission, but also other things like skin and soft tissue infections, and it's just overall not a very pleasant experience. So what we need to do here, and what we really needed to do anyway before COVID, was to think about more innovative ways of supplying needles and syringes and other equipment for using drugs. And I think here we really need to support and learn from what peer networks have been doing. And I'll just give one example of really innovative project, the West Country Respect Drug User Group, which is based in Bath, and it's supported by the DHI service. And they already had secondary needle and syringe provision going on, and two fixed sites, so sort of friendly dealer, friendly peers, where people might go and buy drugs, but they can also get needle and syringe equipment. And they scaled that up to 7 sites from 2. And also included personalised delivery, but also importantly, the peers have supported others to access OST scripts at the start of the lockdown, and these might be people who had no contact with services whatsoever. So there's a real need to capitalise on this, to learn from what peer networks are doing and really support them to scale this up. And I think it's particularly important, COVID or no COVID. You know, before this, I was talking to some street users, street homeless people, and they were saying that they found it hard to find the time to get to the pharmacy to get needles and syringes because they didn't want to leave their pictures. You know, where they were begging on the street, somebody else might take it. If they were begging on the underground, for example, they wouldn't be able to get to a pharmacy to get clean gear. So, you know, we really need to ramp up outreach, secondary distribution, etc. Now, Leon asked me to talk about some of my earlier stuff, and really I like to think about this in terms of attending to pleasures and pragmatics, really attending to what matters most to people, to engage them in perhaps what might matter more to you. So hepatitis C prevention is not a priority for everybody, and a lot of people feel a bit disengaged or sick of risk-focused messaging. But actually, if you attend to what matters most to people, then this can inadvertently help to prevent Hep C as well. And I've given some references at the end of this presentation where you can go and look at work on this if you want. But one example is around vein care. So in the Staying Safe study, we wanted to look at what people who had been injecting for a long time, like at least over 8 years, and have managed to stay safe from Hep C were doing. What was it that was keeping them safe? And we found that many of them talked about prioritising using new works, sterile needles in terms of that they were sharp, that they would help protect their veins, it would help keep their veins going, it would be a less unpleasant injecting experience. Now this makes sense. You know, the most important thing for a drug user, for an injecting drug user, is to keep their veins going. You know, it's crucial, and to really engage with that concern and help people to do this is also important in terms of preventing hepatitis C. All right, so, and again, if we think about the same line, along the same lines, people want to avoid painful injections, and they want to, you know, again, and this can also help avoid vein damage. So what I was really interested in when I first came to the UK was thinking, well, why are people losing their veins so quickly? What I was seeing in the UK were people showing me abscesses, ulcers. People were talking about losing access to the peripheral veins in their arms within 6 months, transitioning to the groin and all of that. So I was a user in New Zealand, and I kept my veins going in my arms for 10 years. And the people around me did too. And I'm thinking, what's going on here? What's going on in the UK? And so we started doing some work looking at how people were preparing their gear, preparing their shots, and the people using a lot more citric here. And so we did a bit of work measuring the acidity, things like that. So yeah, we've written about this, and again, there's a reference there if you want to look at it. But you know, what really struck me when I talk to people is there's a real normalization of painful injections. Now, injections shouldn't be painful, and again, this is going to cause vein damage, which is going to cause, which then leads to transitions to injecting in more dangerous veins like the femoral vein, which is going to have lots of health implications. But also it's important in terms of Hep C prevention, because if people keep on trying for a vein, there's going to be more blood in the environment, all of these things. But most importantly, this is what matters. This is what matters to people. People want to know how to prepare an injection properly, how much citric to use, how to find a vein, how to keep them going. And so if service providers are able to engage people in that respect, then they can develop a much more meaningful relationship, and one based on trust. And you know, if there's an acknowledgement that you know, people are experts in their own right, and to learn from them as well, then that's incredibly valuable. And it's powerful, and also then engaging people with issues around hepatitis C, testing, treatment, etc. Okay, and I realise I'm not like reading through everything on the slides, but if anybody wants a copy of them, please let me know. And also, you know, a lot of the stuff is referenced in the papers at the back. Okay, so I'm quite interested in the moment in this issue of crack pipes. So the issue in the UK is that, unlike injecting equipment, provision of safe inhalation equipment to people who smoke crack, for example, is prohibited under Section 9A of the Misuse of Drugs Act. So this means that a lot of people who smoke crack, if they don't have the money to buy a glass pipe at a store that's being sold as as an ornament or whatever, they're making pipes out of potentially unsafe materials, tin cans, plastic bottles, things like this. So this isn't good for respiratory damage. And you know, the whole issue of COVID really highlights for me the importance of thinking about harm reduction for smoking. You know, COVID is a respiratory illness. People who smoke crack and people who smoke heroin, there are high rates of COPD amongst this population. Also, research shows that probably a lot of those are undiagnosed. So this makes it a very vulnerable population. If people get COVID, then their outcomes are likely to be much worse. So I think we really need to look at how can we help people smoke crack in a safer way. And one of these ways is to provide decent pipes, you know, heat-resistant glass pipes. And this is also really important in terms of reducing COVID transmission, because if pipes are far and few between, if not many people have pipes, then they're obviously going to be much more likely to share them. You know, and if you think about the way that COVID is transmitted, then that's an obvious risk. Now, there's been lots of interventions funded like this around the world, and primarily in Canada. And the rationale for starting these interventions in Canada was primarily around hepatitis C prevention. This is really important for Hep C prevention as well. And if people are using unsafe materials for their pipes, they're much more likely to get burns on their lips, cuts on their lips, etc. And then if they're sharing the pipes, then that provides a window for Hep C transmission. So again, it's relevant, but it's relevant in a broader sense. And it's like what I was talking about before of the pleasures and the pragmatics, and that you're attending to something that matters to people. You're giving them a resource that is important. And people who smoke crack, really at the moment, there's not much use for them in services. You know, what have services got to offer? So this is a really important point of engagement. And this is really more of the same, that I think it's important to change the messaging, not focus so much on you know, Hep C risk, to realise that Hep C is not a priority for everyone, and that interventions can be off-putting. And I really like these posters that the Irish Needle Exchange Forum made, and they did this from some of my research that I talked about around the vein care. And to emphasise, you know, the pleasures of injecting, that it's meaningful for people, that people are maybe invested in keeping their veins going, they may be invested in preparing injections that are not going to be painful, that are not going to damage them. And then this is also important for reducing health-related harms. So just in summary, I think it's really important that we learn from this pandemic. As Jenny said, there's actually been some really good things that have come out of it. Freeing up opiate substitution therapy is amazing. It's something that should have happened a long time ago. We need to move away from supervised consumption, and we need to do everything we can to hold on to some of the benefits that have come out from COVID. But we also need to learn from the innovative things that have happened and capacitate them, enable them to keep going. And so really, that's my spiel. And please feel free to get in touch with me if you want any more information or any papers or anything more. And next slide. So there's some references. So these are the papers that I've referred to, and like I said, feel free to get in touch. Thanks.
Thanks, Magdalena. That's really useful information, because it talks broader than just the needles and syringes, and it's about discussing how we bring people into services, what they need rather than what we want to give them, and what will they accept. And my thing at the moment is all about agency, and it's about that people are more likely to look after themselves if they have responsibility, if they have respect for them, for themselves. So it's about that giving back responsibility to people instead of taking over. So next we have, and so we'll have Magdalena back for questions, and I'm sure there'll be lots at the end. And next we'll have Dave Little, who's the CEO of Scottish Drugs Forum, and he'll talk partly about the past two presentations, but about how it happens. We'll look to Scotland-wide. Anyway, thank you.
Yeah, thanks, Leon. Good afternoon, everyone. I guess what I'm going to give is a bit of a Scottish context to the previous two speakers, which hopefully will help most of our viewers this afternoon. So what I'm going to talk about is broadly the theme of today, I suppose, is that BBV prevention is better than cure. And if I can have the first slide. Jenny's already referred to this Cochrane review, so I won't labour the point, I suppose, other than, it really tells us what we already know, that it's vital that BBV strategies and practices are not seen as separate from drug and alcohol strategies and practice. So what the evidence shows us is that opioid substitution therapy is associated consistently with an average 50% reduction in the risk of new HCV infections among people who inject drugs. And the combined use of high coverage needle and syringe exchange programs with OST is associated with an average reduction in risk of HCV infection by 74%. So we've seen some excellent examples in Scotland of micro-elimination of HCV, both in Tayside and also in Springburn in Glasgow, through treating as many people as possible with HCV. Indeed, SDF have been involved through our peer research programme in the evaluation of treatment as prevention in Tayside. And while we are fully supportive, of course, of everyone being treated for HCV, our view is that prevention of infection should still remain the cornerstone of our response. Even if we eliminate most HCV in an injecting population, the risk of future BBV outbreaks of infection remain. And a current example of this is the continuing outbreak of HIV infection in Glasgow, where we've seen a good level of harm reduction in Glasgow, but due to a combination of circumstances and taking the eye off the ball with regard to testing, we're dealing with an expensive outbreak, both in terms of people and also in monetary terms. Therefore, we need to improve our prevention response. So now I want to briefly go on to look at OST, which in the Scottish context we're now describing as medically assisted treatment, and also injecting equipment provision. Can I have the next slide, please? So for those of you that don't know, Scotland is developing medically assisted treatment standards, and the process is to bring these in obviously over the next period of time. This is work being developed by the Drug Deaths Task Force, and obviously this is in response to the public health epidemic of fatal overdose deaths in Scotland. And I'll just run through the first 5 of these quickly. And obviously the first one that we're looking at in terms of standards, there's 10 standards in total, but I'll just cover the first 5. And basically the first one is around people having same-day access to MAT or OST. Now, this is something during COVID-19 that we've seen quite a disparity in across Scotland, with some areas being very much on the front foot and delivering OST on the same day, whereas some areas indeed have actually limited access to new people almost entirely. Certainly the beginning of the pandemic, things are starting to change now though, with services opening up again. But overall, the intention is that everyone should have access to same-day starts of MAT across Scotland over the coming period of time. The second standard is around choice. And obviously we've already heard from Jenny around the issue of take-home, and certainly this is one of the things that will be developed as part of the standards is the issue of people having the choice around whether they want take-home or daily supervised dispensing. And not to repeat what Jenny has said already, but there is obviously a major change in practice during COVID-19, and we've seen a massive shift away from daily supervised dispensing. And also, as Jenny says, in terms of some of the feedback from service users, we've also conducted feedback, a COVID study that we've undertaken, and that's shown significant support for the move to take home doses of methadone and buprenorphine overall. But although, of course, you know, there are people that want to remain on daily supervised dispensing, and the risk to those individuals may, you know, necessitate that more widely. But I think Jenny talked about potentially it being 10% going forward on daily supervised dispensing, and it would be interesting to have a discussion around that. But I would agree that it should be closer to that level than the current levels in the Scottish context, which are very, very high in specific parts of Scotland. So the third standard is around basically models of assertive outreach, and this is for people who either aren't in services currently or who drop out and the need to follow them up. And we've seen a range of developments in regard to assertive outreach across Scotland, and indeed we're going to be looking at that at the next webinar next week. And a lot of these are focusing on people who particularly have experienced near fatal overdose and the importance of getting those people back into services, or into services for the first time indeed. So we've seen those examples again in relation to the current lockdown, some services being very much on the front foot and seen significant numbers of new people coming into the service, whereas sadly other services have been not so visible, and actually access to new people has been quite inhibited by the lockdown. The fourth standard is around harm reduction services being delivered alongside medication-assisted treatment. And this is something I'll come back to in the next slide. And then fifthly is around the issue of retention within services. And certainly this is, we've observed through our studies and others, this remains a major issue and obviously impacts on issues around, for example, treating people with bloodborne viruses as well. So for example, in the Dundee Drug Commission, the work I was involved in with a range of others, we saw significant numbers of unplanned discharges that the main service there had in the last year that we looked at as part of that work, 452 unplanned discharges. And certainly the work we've done around older people with a drug problem, that's people aged 35 and over, we saw significant numbers of people coming in and out of services. So obviously that, as part of the intention of these standards, is to move to a situation where we reduce unplanned discharge, disciplinary discharges to an absolute minimum. Okay, now just to move on to injecting equipment provision. And again, in the Scottish context, there is new guidance which is coming out relatively soon. As others have already said, the previous two speakers, Magdalena and Jenny, that coverage is not sufficient at present, and that is also the case in the Scottish context. Supply during lockdown has reduced significantly, but we have seen significant innovations during this period, including click and collect and also postal delivery of services. And obviously the hope would be that those innovations are maintained going forward, and actually we further develop these. Magdalena mentioned secondary supply, which is obviously another area that would be useful to look at and does happen, although maybe not that officially in the Scottish context at the moment. And finally, the need to develop provision in MAT OST settings as well, so that becomes a routine part of the service offered with MAT and in terms of the delivery. So if I can just have a concluding slide there, thank you. So I think just to conclude and get into the questions from the audience, prevention is better than cure and certainly more cost effective, as Leon and others have alluded to. I think what we've seen recently is that there's definitely no room for complacency with regard to BBV infections. And obviously the Glasgow outbreak, which continues to be, we've seen new cases already this year with regard to that outbreak, is not entirely under control. And finally, BBV strategies and practices need integrated with drug and alcohol strategies and practice. And certainly there are excellent examples where this has occurred so far, but this needs to be standard practice across the country. And as part of that approach, we need to look at a strategic approach to that integration, which includes the sexual health and BBV managed care networks and alcohol and drug partnerships working more closely together than they are currently. Although again, that is, there are some areas where integration is very, very close, and others where it's less so. So that's me, Leon. Thanks.
Okay, thanks, Dave, for that. And I'd ask all the other presenters to come back on screen, and also Leslie, who's been fielding the questions. Okay, so Leslie.
Hi there. We've just got some questions coming in now. So the first question that we have is asked to Dave, with regards to the MAT standards, over what timescale do you see this being achievable, and how will this be implemented and monitored?
Okay, the timescales are not entirely clear as yet in terms of the implementation, but there has been work being done with Health Improvement Scotland, who would take on these standards and actually monitor and evaluate the implementation. So I think certainly we would want to see that, and others on the subgroup of MAT standards, that those are implemented as soon as possible. And certainly we've seen increasing same-day prescribing of OST and also some of the others in terms of increased choice, for example, around Buvidal. But also we need to look at, and I should have mentioned that in that presentation, around further access to greater choice, for example, heroin-assisted treatment, slow-release morphine, and also the MAT standards. Eventually, I think the intention is that they would also cover stimulant users, prescribing for stimulant users, and also the issue of benzodiazepines. But to go back to the main question, I think yes, is that ideally we would want to see those introduced within the next year or so. But I think that there are significant differences across Scotland in terms of how close people are to implementing those.
Thanks. Okay. Does anyone want to comment further on those?
I just thought when Dave went through them, I thought, well, if they're all achieved, that's it, job done, it's all sorted.
Yeah,
especially all three varieties.
Yeah.
Okay.
Yeah, it was really nice to hear you also mention looking at medication for stimulant use. Like I said, I think this has been a sorely neglected issue, and we really need to be able to provide people with options. Yeah.
And I think what we've seen in terms of the drug-related deaths is that cocaine use is now a significant factor among those deaths, and I think what we don't know enough about is the number of people who are, if you like, primary stimulant users who actually the death is linked obviously to polydrug use, but the benzo and opioid use is actually used as a come down drug as opposed to being the main substance. So I think that's something we're keen that's looked at in far more detail, and that group is seen as different. Obviously, we've got a massive issue of illicit benzo use as well in the Scottish context, as obviously is the case in England, but we've had that historically for many years. But now with all the range of different benzos that are available, I think it's more important than ever that we start to look at prescribing as well, maintenance prescribing of benzos. But of course, there is significant differences in terms of opinion on that among clinicians. And I guess going back to Jenny's comment about the implementation of of the overall standards, that is also the case that there is significant difference. And obviously we have a different context in Scotland to England, where a lot of that provision is in the voluntary sector or the third sector, and where potentially an organisation like CGL or your own, Jenny, in terms of Turning Point, can decide to make significant shifts in practice across all of your services across the whole of England, where in the Scottish context it's individual health boards or local authorities in terms of doing that.
It was interesting in the stimulants webinar we did. Was it Adam Winstop? I think it was. But yeah, his discussion there, and it was about using ADHD medications off license, so to speak, and it working quite well. And what was also significant was the level of ADHD amongst drug users as well. Okay, Leslie, your next question.
Yep, so we've got a couple of questions that have come in about combining prevention of bloodborne viruses with homeless services, and if anyone knows about good examples of how this could be achieved. So we've got mentions here about, is there any research on housing interventions such as Housing First and the impact and prevalence of bloodborne viruses? And also, Dave, you mentioned cooperation with alcohol and drug services, but asking about if homeless services have been factored into this as well. So a couple of questions there about homelessness.
Okay, well, if we go around the panel from the start with Jenny in the order that we presented. So I think we can all contribute. Yeah.
I think that's a really good point. I mean, the thing about housing and Housing First is, of course, it really gets that people can't engage in anything unless their very basic needs are met, and they've got a roof over their head and they're safe and secure. So I'm not aware, but there could be, of studies that directly look at BBV prevalence in housing, but certainly the Housing First outcomes look at engagement, and people engage better in services for those obvious reasons. It's, if your priority is you don't know where you're sleeping that day, how on earth can going to the drug service and getting a finger prick test for a disease that may or may not kill you in 20 years ever be the top of your list when you've got absolutely nowhere to sleep that night. So, you know, I mean, we've seen some, I know it doesn't, slight deviation from the question, but we've seen some really good practice in our areas with the hostels and the hotels, and with really holistic approach to people, you know, taking services to them, taking BBV screen. We've already got, I'm sure you must have it as well, but outreach from hepatology nurses. So just getting people access to treatment for Hep C really quickly, and while they've got somewhere to live, so they're able to think about, you know, taking their medication and you know, what that might mean for them going forwards.
Okay, thanks. Magdalena?
Yeah, thanks, Jenny, and thanks to the person that asked that question. It is an incredibly good point. There's an incredibly high sort of correlation between being unstably housed and having bloodborne viruses, or being susceptible for all sorts of obvious reasons. If you're public injecting, you're going to be rushed, you're going to be, you know, much more likely to miss a vein, it's more likely to be blood, you're going to be appearing in a more unhygienic environment, etc. So, I mean, I think, yeah, obviously housing people is helpful, and again, it's illustrative to look at what's happened during COVID with helping to house people in hostels and hotels. And I think that's been mixed. I think it possibly could have been done better in some circumstances, with more explicit allowance of substance use in the hotels. And, you know, ideally what I would have liked to have seen is incorporation of a safe injecting site in the hotels, in the hostels, actually in all hostels, because, you know, we also have to be mindful of the risk of overdose, and if people are not allowed, so to speak, to inject, they're going to do it alone in their rooms. They're more likely to overdose, not be found in time, and really could have encouraged, you know, social distance, safe injecting by providing sites in the hostels. I think all hostels should supply needles and syringes, and that we really need to sort of look at this and you know, acknowledge that people do use in hostels, and that policies evicting people for evidence of use are very harmful and can be counterproductive. And so I think there needs to be a broader conversation around things that can be done. But, you know, I mean, small steps, but yeah, thanks.
Yeah, there's some big steps for some people in that one. but they actually are very small steps. You know, it's not much to do, but it's a hard line for some people. Okay, Dave, can you add to that?
Yeah, no, just agree with really what's been said in terms of the importance of, you know, particularly addiction services and homeless services working closely together. I mean, there are good examples of that in the Scottish context around, for example, the homeless access practice in Edinburgh that also integrates BBV services within that as well. I think the housing first model is a great model, and as Jenny says, is actually, you know, is all about obviously recognising that people need to be housed first before they can actually deal with a lot of the issues that they're experiencing. And a lot of the time, obviously, we've had the opposite situation where people can only access tenancies once they're, you know, very stable or actually drug-free, more likely, and that is the wrong way around for sure in terms of that stuff. I think one of the issues though is making sure that housing first is well integrated with addiction services, so needle and exchange services, and also OST, so that people have, you know, the best access to that provision as well. Because you can provide housing, but if you have to wait 3 months for access to OST, that's people are not going to be, you know, they're going to find it hard to sustain that tenancy. So it needs to be a package of care that people are provided with. And on the point Magdalena makes around drug consumption rooms, I mean, obviously that this was the intention of the Glasgow drug consumption room, was that actually that was targeted at the street population in Glasgow, most of whom who are homeless. So that provision, yeah, should be there but also should, as you say, ideally would be there in the hospitals as well. And that's, I think, the areas that we've seen that have developed the best drug consumption rooms is that they've developed on a small scale across a range of services rather than seeing one massive drug consumption as being the answer to everything.
Yeah.
Was there a bit there about integration with the MAT standards? Sorry, Leslie, was that the other bit of that? Or?
Well, it was, the question is worded as, Dave, you mentioned improved cooperation with alcohol and drug services. What about services for homelessness? Very relevant in the lockdown setting.
Yeah. No, I think that's exactly right. I think, and the intention would be, I think, to engage more widely. Obviously, the initial task, I guess, is to engage with the clinicians, but then, yeah, the bigger the ownership of those standards, the better in terms of effective implementation. So I would agree entirely with that.
Okay, thanks. Okay, Leslie, next one.
A couple of questions have come in about, one, do we think there's likely to be further implementation of postal IEP across Scotland? And in terms of the challenges faced by substance use services, do you guys have thoughts on how we might improve harm reduction and access to harm reduction going forward? So a couple of questions just about different ways of delivering services.
Yeah, on the first one, I'll just quickly answer that around the postal delivery within the IEP guidelines, which are coming up with the injecting equipment provision guidelines. That's one of the recommendations we've done through the Scottish Needle Exchange Workers Forum. We've done work on the postal provision, which actually was on in November, and it was highlighting there was an Australian service which had been doing it in Western Australia. And it was actually very timely, and that people had an idea of different ways of providing needle exchange. One would hope it's in the needle exchange, it's in the nation.
We have someone who come in while
Leon.
Yeah. Okay.
Well, I mean, I could add to that maybe first in terms of certainly the postal delivery we have seen. I'm not sure we're clear about the extent of that so far, and across whether that is the whole of Scotland. There has been talk around Scottish-wide provision around that. So I think that would be something that one of the lessons around COVID-19 is to look at actually what has happened during the lockdown and learn the lessons of that in terms of trying to integrate that into services going forward. But obviously what we have seen is, as was mentioned by Jenny, the queues outside of pharmacists and the deterrent of actually accessing equipment. So I think we need to look at the whole range of provision, and obviously the assertive outreach models around non-fatal, near-fatal overdose and bringing people onto OST. But yeah, we should also look there as part of that development as well.
Mm-hmm. And then we were looking at further harm reduction provision. Go to Magdalena on that one. What other things could we do in harm reduction that?
Well, I sort of mentioned a fair bit already, but it'd be great to have much more of a grassroots focus back on harm reduction services, so that people would ask questions about how to properly prepare an injection, how to find a vein. There was a broader range of equipment provision, for example, for people who use stimulants, for people who smoke illicit drugs. I think just more of an openness around using, and it's so sad to have to say this, but there still is an emphasis on moving people towards abstinence. You feel that they can't talk about injecting, that they have to keep it hidden, and this is hugely detrimental for a whole host of reasons. So we can really help to reduce a lot of health harms and to help engage people in services. I'd like to see workshops on safe injecting technique, especially for women, and really thinking about the needs of women in services, I think is very important. A lot of women I speak to, they may rely on their partner to inject them, to prepare the mix, to all of these things, and that's profoundly disempowering and can keep people in sometimes in abusive relationships. So there's lots that could be done. We could talk about for hours. It's just a little initial thought.
Jenny, any further on some of your work?
I mean, I have to reflect on the English context because that's what I work in, and I'm not sure if this applies in Scotland. Obviously, I have to leave that to participants to see if any of this chimes with them. But you know, we've had a recovery-focused agenda in England now for 10 years. We've got a drug strategy, which, however way you look at it, is interpreted, and I think probably does direct people towards abstinence-focused treatment. So I think if I had to pick one thing we could do in England to improve harm reduction, access and delivery, it would be about the workforce. So I think increasingly I find people who work in drug services don't actually have that much harm reduction knowledge or expertise, not like they had in the old days. I mean, way back when I worked in Aberdeen at Drugs Action, you know, we were, and I'm sure as a service it still has this focus, but you know, we were very much focused on the things Magdalena talked about. And yet I've had recovery workers sitting with me in clinic, and I've been talking to groin injectors about, you know, finding veins and peripheral sites and looking at those sites and saying, how about that vein, and talking about, you know, safer injecting, and recovery workers say to me, are you allowed to tell them that? You know, so I really think we need to upskill the workforce and get across the stigma. People feel very ashamed of injecting. So we need to skill the workforce to talk to people about injecting. You know, it's okay, we can help. Our focus is about your health. We're not here to judge. And to give people proper harm reduction training so that they can deliver that across the ranges where people engage. I mean, our guidelines on needle and syringe provision say that, you know, drug treatment services should be providing needle and syringe provision, and that should be completely integrated with treatment access as well. And yet it feels at times like it's not.
As Magdalena was saying before about the messaging that we're putting to it, in a way, you know, it's hard if the messaging is negative, is anti, and that then kind of the workers take that messaging aboard as well, instead of how do you know, using carefully, using safely, using as well to get as good a use of those drugs as possible. And that then kind of makes it more matter of fact, I suppose, in that situation. Okay, Leslie, the next question.
These questions, they keep on coming, so we do have a lot of questions here. Any thoughts from the panel on preventing the reinfection of Hep C, people who have already been treated? And do we just do the same as we do treat everyone the same, or is there more messaging, more specific messaging that we should be giving?
Probably part of this webinar today was based on the reinfection rates, etc. For me, I'll just quickly say I don't think we should do anything different, as in we just focus on stopping transmission and the various ways we've discussed today. But I'm happy to hear further thoughts. Jenny?
I mean, one thing we do in our service, as I said, we have an outreach nurse from hepatology who comes and delivers people's Hep C treatment in our service. And she very much talks to people about harm reduction stuff, like accessing clean equipment, about avoiding reinfection, and about supporting them. But you know, by nature of how we have those people, they're already on OST. So I think it's maybe just about emphasising. As Lena says, it's not even different. It's just that works. That emphasis works, and when they see that the treatment nurses are really on board, people engage quite well. So I think just, yeah, you can't have too much harm reduction.
Dave?
Yeah, I mean, one of the things that we've seen among the services, you know, with the lockdown, the ones that have been on the front foot have actually seen more people coming into the service than they had this time last year. And that is because I think for some people it goes back to the daily supervised dispensing, that they actually know that the service won't operate in the same way that it used to do. So I think that that's one of the aspects to this as well. If we reduce the daily supervised dispensing, we actually lower the threshold for access to services, which means that more of those people can access the service. I mean, the suggestion is that we maybe have 40% of people, you know, on OST of the overall population of people with drug problems, and actually the better countries, obviously, that have their problems, if you like, more under control, have 60–70% of people in the service. So I think that's one aspect to this as well. If we have better OST, which has more choice in a number of respects in terms of the drugs provided, but also in terms of you know, the swiftness of access and the issues around dispensing regimes as well, we can pull more of those people into services so that their risk of actually getting reinfected is less.
Mm-hmm. Okay, thanks. Magdalena?
I guess, I mean, I'd be interested, I think we should learn from people who get reinfected, right? You know, like ask them what's going on. What are the circumstances? What are the contexts in which you think this happened? You know, they obviously don't need, you know, more information, but you know, is it the context of requiring somebody else to sort out your hit for you? Is it that you weren't able to access needles and syringes in the location that you're in? You know, so I mean, it's all very well for us to hypothesize, but let's learn from people, from the experts, about what they need and what we can do to help avoid reinfection. And I just think ramping up needle and syringe provision is paramount, you know, through lots of diverse ways. And yeah.
And just maybe to add to that, Leon, obviously what we saw, or what we've seen in the Glasgow HIV outbreak, is that cocaine use alongside opioid use is a key factor in terms of increased episodes of injecting and increased risk. So that's one of the key drivers around the HIV outbreak. So yeah, in that sense, and again, you know, to my mind, that goes, I mean, obviously to injecting equipment provision, but also in terms of things like heroin-assisted treatment. So people are actually, they're seeking the euphoric effect of a drug, but actually could most benefit probably from being on heroin-assisted treatment. So it's around choice and options for people.
Okay.
I just want to say something.
Yep.
Really good point, Dave, and everyone's points are really good. But I think we need to really reassess what we think of as optimum coverage as well. So the care and prevent study that I've been conducting, you know, we did a survey with 455 people who inject drugs in London, and we asked them how many times they injected a day, but also how many times it took them to get an injection, right? So I think there may be an assumption amongst people that one needle and syringe per injection is somehow good coverage. It's just not. You know, a lot of people who've got damaged veins, they may need to use several needles and syringes to just get one injection. And in some of the qualitative work I've done with people, there's one guy who said he would go through 7 needles and syringes to get an injection. And so, you know, a quarter of the participants were injecting 4 or more times a day, and a quarter of the participants, again, not necessarily the same people, were taking 4 or more attempts for each injection. So if you think about how many needles and syringes they would need, it's masses more than what is commonly accepted coverage. So I think we really need to be much more ambitious around what we see as adequate coverage. And you know, I mean, ideally, I'd like to see needle and syringe vending machines alongside condom vending machines in toilets, for example. You know, why not? I think it's about we really need to challenge ourselves and think a lot more broadly about how we get things out there, how we destigmatize, and how we remove shame. You know, I think what Jenny talked before about upskilling the workforce is really important as well, and it's really about getting rid of any of those shaming messages, any of those posters on the walls that provoke shame, because shame is the biggest barrier to service access, biggest barrier to seeking help, you know, and it's endemic, and it's really sad, you know, and so I think that this is what we need to do. So thanks.
Cool, thank you. That was excellent. Leslie?
Next question. We've actually got a worker here who's asked if you could recommend any books, guides or anything. It's a recovery worker who could do more reading on the topic of harm reduction and how to give advice. So if anyone's got any recommendations for books or papers, Magdalena.
Magdalena, all of Magdalena's papers are very interesting.
Not my papers. Exchange Supplies they've got some great stuff. I would look on the Exchange Supplies website on their publications. Most of them should be free to access or to download. But yeah, I mean, there's some really good stuff from users organisations like Input, AVIL, Vandu. So AVIL have got good stuff. So that's AIVL if you put it in. Yeah, I'd look on user forums for easily accessible good harm reduction information and advice. There's stuff out there. It's not necessarily easy to find, but you can start off with Exchange Supplies.
Jenny?
Yeah, I mean, yeah, Exchange Supplies obviously my recommendation as well. I mean, Magdalena and I both do work with them as well. I think if somebody's really new into the field, perhaps hasn't worked in drugs field before, we've just launched with Exchange Supplies some needle exchange training online, which is free to access, and you don't even have to register unless you want the certificate. Then you have to put in an email address. And although it's written to align with the NICE guidance on needle and syringe provision, it's got applicability, obviously in Scotland as well. The one that's live at the moment is the level 1, so that is really aimed at basic introduction, people new in drug treatment and particularly pharmacy staff. And then shortly we're going to have level 2 and level 3, so aimed at more advanced practice. But when I started out in the field, a book that was absolutely my Bible was the Safer Injecting Handbook, which Exchange Supplies took over production of. It was written by Andrew Preston and John Derricott. That was absolutely essential. I learned heaps from that.
Dave?
Yeah, just to add to that, in terms of obviously we're funded by Scottish Government to deliver workforce development training, so I have a range of training that people can access if they look on our website for that, both e-learning and well, at the moment virtual training as opposed to face-to-face, but we can provide that as well. So
yes, and our section can provide some of that as well. So it's, yeah. Yeah, there is a wide range of stuff out there. It's like, but it depends on what approach you're coming from and what language because some of the harm reduction stuff initially, and I think this is the issue with staff, is that it appears confronting, but actually if you work it through on a scientific basis, it's not. It's just good technique to use as well as possible, and it's and when you put those together, then you have a safer technique and less BBVs, etc. Okay, Leslie.
So I've got a couple of questions that have come in from people about staff being trained up or using the lived experience of people. Has anyone had any good experiences, or what are people's thoughts on staff working in services learning from the people who use the services or have experiences of using the services?
Who'd like to answer first on that one? Jenny, Magdalena? I'll go down the center of my screen as Magdalena, so it's you first. Sorry, that's why I kind of go to you. So.
I mean, yeah, absolutely. I mean, I think, you know, why not work with people in the service to run safe injecting workshops? I mean, you know, talk to them about what they need, capitalize on the experience. Absolutely. I mean, it's vital. It's a bit of a no-brainer, really. So I mean, the more peers that are working in a service. I mean, it would be great to see, you know, a peer-run, peer-led service. When I was in New Zealand, I worked at a peer-led needle exchange, and it was great. You know, people would come in, they could sit down, they could have coffee, they could show you their veins, you know, ask questions. There was no shame, there was none of it, because we were all peers, you know, and it was completely disconnected from methadone prescribing or anything else. So I think the more incorporation of peers, but also capacitating peer networks, like I said, to provide secondary exchange of needle and syringes. But yeah, you know, talking to people and finding out what they need, working with peers on delivering safe injecting workshops. I mean, yeah, it's a great idea.
Jenny, and turning point?
What I would like to see would be more opportunity for people who still use drugs to work in drug services. I think we still have barrier requiring people to be abstinent. I work with some brilliant people who have been through the treatment system who have used drugs, and they have a huge amount to offer, but I would also like to add to that offering people who are currently using. I think we could learn a lot from them, and I think actually they might actually also get quite a lot from making a contribution. Being devil's advocate, there's one area I think that sometimes we need to be cautious about, and that is people making the assumption that their experience and their circumstance translate to others. And I think that's true of everybody, whether, you know, whatever your job role is. So I think we do have to support people, even people who have lived experience and understanding, you know, about meeting people where they're at, and not sort of saying this works for me, so it'll work for you. But yeah, definitely I'd like to see more people who are still using, actively using, working in, you know, and in a flexible way, so they could come in when they can come in, and they, you know, there's no high threshold about if you don't come in at this time and do these hours, you're not getting this job. There's some good models.
Yeah, no, I would agree with that. I mean, we've done a lot of work around peer supply of naloxone, and that model, you know, could easily be extended to other delivery. I mean, it is interesting. I mean, we run an addiction worker training program, which is for people who have, you know, who are drug free. But I think what is interesting about that program is that very point that you make. Most of them come through, I suppose, Narcotics Anonymous or other, and actually over time, you know, through the training and delivery of that actually they get to understand about the wider range of provision. And actually, it's not about their own personal view. It's actually about the person that they're working with, and that's about the relationship with that individual. So, but I think, yeah, certainly we've been looking at extending that program, you know, more widely. But the challenge of that has been, to some extent, I suppose, that the services and the placements that we provide. So we need to have consensus, I suppose, that that's something that everybody would support as part of that.
Okay, thanks. So unfortunately, I'm going to have to wrap this up because we've come to the end of the webinar timing. This has also been recorded and will be published soon on the STF YouTube channel, including replies to the panelists and any of the other questions we didn't get time to get to today. We'll also be sending out an evaluation, and it'd be excellent, most excellent, if you could complete that for us. The next webinar is next Friday at 1 p.m. again, and the topic of that will be assertive outreach in Scotland during the lockdown and after. And a link to the register for the next one will be in the evaluation email. Injecting drug use is the primary transmission route in Scotland of hepatitis C and other viruses and illnesses, and prevention of hep C and other infections is dependent on ensuring people who inject, who've ever injected drugs, are informed on injection risks, safer injection practice, have access to clean injecting equipment, and timely low threshold access to appropriate testing and treatment. And what we've talked about today is about the information and the way in which they feel about accessing the service. We need to think about what their needs are, not what the service needs are. So finally, I'd like to thank you all for attending, and a special thank you to today's speakers, Jenny, Magdalena and Dave, for what's been really informative and engaging session. And thanks again, everyone, and goodbye.
Cool. Thank you.
Thank you.
Bye.